Hello friends, today we are going to see a very interesting topic that is uterine prolapse. Welcome you all to this session.
Uterus has been supported by different ligaments, muscular and fibromuscular support, and that is why uterus is always in its normal position. The anteversion anteflexion of uterus helps it to maintain its position. Because of this anteversion and anteflexion, whenever there is increased intra-abdominal pressure, still the organ doesn't come out of the vagina, but it gets just buckled. Thus is mechanical axis of uterovaginal canal, and this is very important to maintain the position of the uterus. The muscular supports are vaginal diaphragm, which is mainly formed by the levator ani muscle, the perineal body where the muscles come and meet, and urogenital diaphragm, which is formed by superficial and deep transverse perineal muscles. All these muscles together, they form a diaphragm on which the uterus is put, or it's been supported by this diaphragm. We can compare this with a ship which is floating on water. Because there is water, the ship can float. If the water is taken away, the ship will sink. So this diaphragm, it acts as water and supports the ship of the uterus whenever there is increased intra-abdominal pressure. Other fibromuscular supports which are actually supports of the uterus are pubocervical ligament, as the word suggests, from the pubic symphysis to the cervix anteriorly. Transverse cervical, it is a fan-shaped fibromuscular band from the cervix going outwards. Transverse cervical ligament, or it is also called as cardinal ligament or McEnroth's ligament. And uterosacral means from the uterus to the sacral body. So this is the other ligament. So these all are primary supports of uterus. Mechanical axis, muscular in the form of the diaphragm, and fibromuscular, and in which the most important two supports which really support the uterus to maintain its normal position are transverse cervical, that is also called as cardinal or McEnroth's ligament, and the other one is uterosacral ligament. Secondary support of the uterus are round ligament and broad ligament. They are not actually acting as supports of the uterus. Round ligament to a certain extent help to maintain the anteversion and anteflexion position of the uterus, and broad ligament, it just carries the vessels and all, but it doesn't really act as a support for the uterus, so they are called as secondary supports of the uterus. We are talking about prolapse. That means the uterus leaves its normal position and comes out through the vagina to certain degrees. Prolapse can be uterine, where only the uterus travels down, or it can be uterovaginal. That means when the uterus is coming down, some portion of the anterior vaginal wall and the anterior organs like bladder would also get descended into the vagina, and posteriorly the posterior vaginal wall along with other organs like the pouch of Douglas or the rectum can get descended, and that is called as uterovaginal prolapse. Now let's see definition wise. If there is prolapse of anterior vaginal wall, upper 2/3 portion along with the bladder, it is called as cystocele. So prolapse of anterior vaginal wall, upper 2/3 along with the bladder is called cystocele, and lower 1/3 of anterior vaginal wall along with the urethra, if it gets prolapsed, it is called as urethrocoele. Posterior vaginal wall, prolapse of upper 1/3 along with the pouch of Douglas, it is called as enterocele because it may contains loop of intestine, and prolapse of posterior vaginal wall, lower 2/3 along with the rectum is called rectocele. These are the vaginal prolapses. Uterine prolapse, normal position of the uterus, that means this external os is at the level of ischial spines. Once it starts descending down from this position, we are having different degrees of prolapse according to the position. If the cervix just leaves this position of ischial spine and comes down in the vagina itself, it is called as first degree prolapse. When the cervix reaches up to the introitus, it is called as second degree prolapse. When the cervix peeps outside the introitus, it is called as third degree prolapse. And when whole of the uterus along with cervix sits outside the vaginal introitus, it is called as procedentia, where entire uterus is out. Prolapse is also classified by a different new technique or method. This is called as POPQ, pelvic organ prolapse quantitative scoring system. In this, stage 0 means no prolapse demonstrated. Stage 1, most distal portion, that is the external os, is more than 1 centimeter above the hymenal plane. So over here, hymenal plane is considered as the point of what we can say is from that hymenal plane we are grading this prolapse. So if the external os is 1 centimeter above, more than 1 centimeter above, it is stage 1. In stage 2, the most distal portion of the prolapsed organ is within 1 centimeter, either above or below the hymenal plane, it is stage 2. Stage 3, the most distal portion is more than 1 centimeter below the hymen, but the TVL, that is the total vaginal length, is just less than 2 centimeter of normal. So no vaginal eversion has taken place. In stage 4, vaginal eversion occurs because most distal portion of prolapse is more than TVL minus 2 centimeters. So this is POPQ, quantitative scoring of the prolapse. Now, why prolapse take place? There are many reasons. Congenital reason, if there is spina bifida or split pelvis, that leads to neurogenic weaknesses and leads to prolapse. Most commonly, whatever prolapse we see is because of the trauma and as a complication of vaginal births. Things like perineal tear, pudendal nerve injury, they lead to prolapse. Many a times we see that deliveries are conducted by untrained guys or some relative of the woman. In such cases, she is asked to bear down even before the full cervical dilatation. So she is actually trying to push the baby out against incomplete cervical dilatation. The cervix is still not completely dilated. In such cases, there is trauma and that will reflect later as uterine prolapse. In cases of big baby, there would be tear or there would be injury to the perineal muscles, and this injury will heal with fibrosis, which will lose its tensile strength and thus leading to prolapse. So birth trauma, forcible deliveries is a very common cause of prolapse. Again, after one delivery, the woman should get some time to regain the muscle tone back. So perineal exercise is to be done, she should be given rest. But if there are repetitive births or successive deliveries with less duration in between, she doesn't get much time to recover its normal tone again, thus leading to prolapse again in future life. Prolapse is quite commonly seen in perimenopausal and postmenopausal women. So postmenopausal asthenia or atonia is also a cause of prolapse. Usually there is estrogen deficiency and that affects the muscular tone, and there is this asthenia which leads to prolapse. Conditions where there is constant raised intra-abdominal pressure, that will also precipitate prolapse, like chronic cough or a woman who's having, she works where she has to lift weight continuously, strenuous activities. In these cases, there is increased intra-abdominal pressure that will lead to prolapse much more commonly. Etiology of prolapse is very important, and in which birth trauma is to be considered as the most common cause of prolapse. What would be the symptoms? Patient usually comes to us saying that something coming out of vagina. So we call it as SCOPV. Because the organ is getting prolapsed, there would be stretching of the uterosacral ligaments, and that will lead to mild sacral pain. So at the sacrum there would be pain which is mild. Because of the prolapsed organ in between her thighs, she would have discomfort on walking. that would be the organ would be exposed to the exterior, and that will lead to irritation, discharge or bleeding. Sometimes there is presence of decubitus ulcer which also bleeds, and that will lead to some blood stained discharge. Urinary, because of anterior vaginal wall prolapse along with the bladder, there would be symptoms like frequency of urination or feeling of incomplete evacuation. Means usually the bladder is situated up and the urethral opening is down. So whenever the circumstances allow, detrusor muscle contract and the sphincter gets relaxed and urine is passed. In cystocele, what happens? Some portion of the bladder is below the level of the urethral opening, and because of which whenever she tries to pass urine, some of the urine is passed but some of the urine still remains and the bladder is incompletely evacuated. So as soon as she gets up from the squatting position, once the bladder comes to normal position, she again has the feeling that she has to go to the toilet and she has not yet completely evacuated the bladder. This is very classical of big cystocele, which is called as feeling of incomplete evacuation of the bladder. This thing can also lead to incontinence, which can be stress or urge. Stress incontinence means whenever she stresses, like she coughs or suddenly she laughs, or if she lifts up some weight, when she does this activity, there can be release of some urine, which is unknowingly. She cannot hold that urine back and she cannot control it. That is called as urinary incontinence. It can be stress or it can be urge. Urge incontinence means patient feels that she has to go to the toilet. She moves towards toilet, but before she reaches in the state where the bladder is filled, till she squats and passes urine, before that only some urine is leaked. So that is urge incontinence. What are the complications of prolapse? Decubitus ulcer is most commonly seen on the prolapsed organ. Usually, it is thought that the ulcer is because of friction. But the position of the ulcer which is seen is on the most dependent part of the cervix. That means either on the anterior lip or on the posterior lip. So if it would have been because of friction, it should have been on the lateral edges of the cervix. But it is seen on these two sides more commonly. So what is the cause of decubitus ulcer? Again, it is an important question from MCQ point of view. Basically what happens, as the organ is getting prolapsed, the venous return is getting affected because of kinking of vessels. As the venous return is affected, there is stagnation of this blood, and that leads to ischemia. Ischemia leads to necrosis, and thus there is ulcer. So cause of decubitus ulcer, the first thing is ischemia and necrosis. Friction may add to it, but main cause is ischemia and leading to necrosis. So decubitus ulcer seen on anterior or posterior lip of the cervix. Chronic cystitis, that means bladder infection, because the bladder is filled, it's not getting evacuated or getting only half evacuated. So whatever urine remains for longer time, it is likely to get infected, leading to chronic cystitis. There can be obstructive uropathy because of kinking of the ureters as it gets pulled in. Incarceration of prolapse, it is rarely seen but can be there. There would be gangrenous changes of the prolapsed organ. Iatrogenic complications, when we correct the surgery, or there can be enterocele or walled prolapse later. Vaginal carcinoma is mentioned in your book, but it's very, very rare. So main complications of prolapse would be decubitus ulcer, cystitis, obstructive uropathies.
How to prevent prolapse? Is it preventable? Yes, of course it is preventable. If we do following things, then we can prevent prolapse.
So if we give them proper care during labor, that means if deliveries are conducted in the hospital, episiotomies are given on time, bearing down is to be done only in second stage when the cervix is fully dilated. There has to be proper spacing in between two children so that she gets time to regain her muscle tone back. Big babies or whenever there is CPD, cesarean section is to be preferred instead of delivering the patient vaginally by leading or by doing this, delivering forcefully, there would be trauma to the perineal muscles, perineal body, thus the supports of the uterus will be affected. So all these things done in labor properly would lead to prevention of prolapse. Again, we can advise the patient Kegels exercises in antenatal and in postnatal period so as to get tone which is lost during labor. So she can do these exercises. In postnatal period, after 24 hours of delivery, she can start Kegels exercises. What are these Kegels exercises? We ask the patient to hold on to she has to contract the pelvic muscles as if she is holding on to the act of micturition, means she is not allowing herself to pass urine. The way she holds it up, she is supposed to hold it up for a while, count 5 numbers, release the muscles again contract and release. This she is supposed to do at maybe for the count of 20 in the morning, afternoon, night. So these muscles are actually trying to give the tone back to the muscles which has become lax. Episiotomy given in second stage and proper second stage management will also avoid prolapse. Prevention of undue perineal stretching. As I said, if we suspect CPD or if we suspect that there is big baby, then we should prefer cesarean section on vaginal delivery instead of going and tearing the perineal tissue. Early postnatal ambulation and exercises would again help, and avoiding childbirths at short intervals will definitely prevent prolapse. There is something called as ring pessary. It is made up of PVC or silicone used for palliative treatment in patients, but please remember, ring pessary is not a permanent treatment for prolapse. In young women planning pregnancy or if they are pregnant and having prolapse, up to 18 weeks we can use ring pessary just for some time, because wearing a pessary is very difficult and uncomfortable to the patient. So it's not a treatment of choice, or it's not a treatment to be given for a longer period of time. She can use it for a while in pregnancy or during puerperium, or maybe sometimes if there is decubitus ulcer, and for healing of that ulcer or for getting the infection clear, we can use ring pessary for a while. Sometimes it can be used in women who are unfit for surgery, but again it depends on her comfort level, how far or how long she wants to use it. Complications: if this pessary is forgotten, it can lead to vaginitis, ulcer, vesicovaginal fistula, or even cancer vagina. So this pessary is to be removed every day, cleaned and reinserted to avoid infections. But if it's forgotten, it can lead to these changes. As we discussed, decubitus ulcer is because of venous congestion and ischemic necrosis. So now, to treat it, what should be done? Because the organ is prolapsed, the vasculature is affected, venous return is decreased, leading to congestion, leading to necrosis. So treatment is to put the organ back to its anatomical position. Then only the venous circulation will improve, fresh blood would come in, and the necrosis or the ischemia would be corrected. So for this, treatment is reduce the prolapse to its normal position, and to avoid it from getting prolapsed again, we can use daily packing with glycerin and acryflamine. Glycerin has hygroscopic action, so it reduces the edema, And acreflavin, it acts as antiseptic. So whatever infection is around, it takes care of that. Now we have treatment for prolapse. Prevention we have done with the help of Kegel's exercises and whatever things we have discussed. Pessary to certain extent. Estrogen creams to certain extent in perimenopausal or postmenopausal patient. Now what are the surgical modes? In surgical modes also we have conservative surgeries where uterus is still conserved and prolapse is treated. And some surgeries are radical where we take out the uterus, that is hysterectomy. So in conservative treatment we have anterior colporrhaphy. What is anterior colporrhaphy? It is the repair of cystocele. In this what do we do? Prolapse of anterior vaginal wall along with bladder. So we take an inverted T-shaped incision on the anterior vaginal wall. The dissection is done in vesico-vaginal fascia. The anterior vaginal wall is separated from the bladder. The bladder is pushed up. Excessive portion of the anterior vaginal wall is cut. The fascia, we took buttressing sutures in the vesico-vaginal fascia and tightened that fascia, and then the anterior vaginal wall is closed after that redundant portion is being cut. So this is a surgery where the cystocele is reduced but we are conserving the uterus. So cystocele is treated with anterior colporrhaphy. Posterior colpoperineorrhaphy is a treatment for rectocele. Similar surgery. The lax vaginal wall is first separated from the rectal wall. The dissection is in the recto-vaginal fascia, that plane of fascia. Then the fascia is sutured or tightened with buttressing suture, and then the redundant portion of the posterior vaginal wall are cut, and then the wall is sutured. In between we can approximate medial fibers of levator ani so that this gets more power or it will avoid further prolapse. This is also called as colpoperineorrhaphy because levator ani is close together, and the vaginal opening also we reduce in size vertically suturing. So it is we are doing a corrective surgery on the perineum as well. So posteriorly it is called as posterior colpoperineorrhaphy. It can be combined with anterior colporrhaphy and with vaginal hysterectomy if required. Means suppose a patient is postmenopausal, she has prolapse, along with that she has cystocele and rectocele. She doesn't want to have reproductive function or she doesn't want to have uterus. We can do vaginal hysterectomy and do anterior colporrhaphy for the cystocele and colpoperineorrhaphy for rectocele along with the hysterectomy. Or it can done as a conservative surgery. Only cystocele, just do anterior colporrhaphy, conserve the uterus. Rectocele, just do colpoperineorrhaphy and conserve the uterus. Enterocele. Enterocele is prolapse of pouch of Douglas, that is the posterior vaginal wall, upper 1/3. It may also have intestines, they may get stuck over there, may land up in gangrene, so we have to have enterocele repair. There are two ways, abdominal and vaginal. Abdominal enterocele repair is called as Moskowitz repair. In this, we start from the lower portion of the pouch of Douglas. This is done abdominally and start taking pursing sutures at different planes. Starting from the lowest plane, pursing suture, closing it, then a little above, pursing suture, closing it. So it reduces the enterocele by pursing sutures of POD from below upwards. From below upwards, we go on taking pursing sutures in different planes and obliterate that space. This is called as abdominal enterocele repair. We can also have Albin repair, and vaginally it is called as McCall caldoplasty. These are the enterocele repairs. For women in reproductive age, if the uterus, if the cervix is coming out, we have different surgeries. We have till now discussed vaginal prolapses. Now we are concentrating on uterine prolapses. So uterine prolapse treatment will depend on age of the patient, will depend on whether it is a congenital prolapse or it is secondary prolapse. So in congenital prolapse, what happens? The infravaginal portion of the cervix is elongated. Infravaginal portion means where the vagina is attached to the cervix, the portion above is called supravaginal, the portion below is called infravaginal. When there is elongation of the infravaginal portion, that peeps out to the vaginal introitus and causes prolapse. Deep fornicis is a sign of congenital prolapse. In this case, we can do Fothergill surgery where the principle is we do amputation of the excessive portion of the cervix. 2.5 centimeter of the cervix is left behind and excessive portion of the cervix is amputated. This is done. Before that, we need to have McIndore's ligament cut, separated and then brought in together to support it. A descending cervical artery branch ligated. We do DNC so that next formation of new external os would be easier. We also do curettage so that any endometrial pathology can be ruled out. So Fothergill surgery is a common surgery done in cases of congenital prolapse, deep fornicis. It has got certain limitations. It can lead to decreased fertility because the os which is formed can have cervical stenosis, or it can be an incompetent os leading to either repetitive abortions, or it can be stenose leading to cervical stenosis. It can also lead to dystocia in labor. So the new os which is created is not as good as the original os for the sake of fertility of the patient. So if you have a question, a young woman having prolapse and desiring fertility, then Fothergill's doesn't remain a choice of surgery because Fothergill surely affects her fertility.
So for today's video and rest of the prolapse, we will see you next session. Thanks a lot.